السلام عليكم. والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. First of all, I would like to thank the organizing committee for giving me this opportunity to give this talk, and I'm very humbled and honored to come back to King Abdulaziz University Hospital and to give a talk in front of my teachers. I mean, Dr. Nasrat, Dr. Hassan Jamal, and Prof. I mean, I'm really honored, and I'm not sure if I'm qualified to speak in front of them. Anyways, I would like also to have a special thank to Dr. Khalid Seat and his group for their efforts in making this happen. Following Jim Bentley is not a good idea, but anyways, that was the way it was scheduled. Khalid asked me to give a basic review of medical treatment of hyperplasia and endometrial cancer, and this is basically, in compared to yesterday's talks and last night, this is going back to basics. It's more of clinically oriented and more practical to the day in, day out, and it's directed to the general gynecologist who is sharing with us the management of gyne-oncological cases. Again, not every gyne-oncological or pre-malignant case can be treated with a small group of gyne-oncologists with a big population. So, I mean, there is a big pie of lots of job, and I would like the general gynecologists also to share with us. So without further ado, I'm going to start talking about the first to the endometrial hyperplasia and then moving on to the cancer. Before we start, we have to know that the endometrial hyperplasia and eventually subsequently endometrial cancer, it's a disorder of a gland. So we have to understand the function of this gland, the anatomy of this gland, as well as its pathological feature, physiological and pathological features in order to understand the disease entity. Endometrial hyperplasia, it represents a spectrum of morphologic and biological alterations of the endometrial gland and stroma, ranging from an exaggerated physiologic state to carcinoma in situ. It results from protracted estrogen stimulation in the absence of progesterone influence. And by the way, we have a big population who are morbidly obese, diabetes. Diabetes, by the way, as you know, it is now becoming epidemic, and we are unfortunately, Saudi Arabia is taking the lead now in the incidence of diabetes. And the problem is not under control, it's a national problem. And with diabetes comes obesity, with women comes like malignancies or hyperplasias. Endometrial hyperplasia, the risk of endometrial hyperplasia progression to carcinoma is related to the presence of severity of cytologic atypia. It's very important to understand the basics, and by understanding and mastering the basics, we can predict what is going to happen afterwards. Progesterone therapy is very effective in reversing endometrial hyperplasia that is without atypia. We have to understand when we talk about hyperplasia, we are looking into two different aspects. The aspect at the glandular level, which is hyperplasia, is it simple or complex? And then we focus to the cellular level, atypia or not. It's very important to look at these two levels because the prognosis, progression to cancer, and management differs. Again, when it comes to diagnosis, it's very simple. And I'm saying very simple because it's an office test. You do endometrial aspiration, and this is the first step in evaluating a patient with abnormal uterine bleeding. The diagnosis accuracy of the office-based endometrial biopsy is 98%, and there is a critical review over about almost 14,000 compared this to DNC, showed that the complications of DNC is way much higher, but the specimen accuracy is comparable. Why I'm saying this? Because of two reasons. Our fellow gynecologists sometimes get reluctant to do the biopsy. There is two aspects. whenever you are in doubt, do biopsy. I never regretted doing a biopsy, but I regretted so many times not doing one. So doing a biopsy is, you have to have a low threshold on it. I'm not saying that we do biopsy on everybody, but there is certain areas that we have to increase the level of suspicion and just go ahead and do biopsy, especially if in the clinic. The other part is that don't go to the more invasive one, DNC hysteroscopy, because part of my duties in Dhahran as a gynecologist, also I take care of to observe the quality that provided to Saudi Aramco patients all over the kingdom. And I do see ways of managing things all over the place. I mean, people shy away from endometrial biopsy, especially in the private sector, and go immediately to hysteroscopy DNC, which is not the first choice. You are exposing the patient so many risks by starting this. Anyways, I'm not saying that we don't do it, but we have to go stepwise. If the initial biopsy result is negative, further evaluation is recommended in patients with persistent symptoms due to the high risk of existing lesion having been overlooked. Again, if it's a stenotic cervix, there is so many tricks. You can do so many things. You can give misoprostol, ask the patient to come back, before taking patient to the OR. I cannot stress enough on how much endometrial biopsy in the clinic is number one step. Again, ultrasound is a way of diagnosing it and to see the thickness, but when it comes to diagnosis, we need tissue biopsy. Again, doing a biopsy is one thing and reading the pathology report is something else. Again, we have, with all my respect to all pathologists, we have different type of quality of pathologists all over the kingdom. And again, when you do a biopsy, it is as important as doing it is reading and knowing what you are expecting. So you have to know what you are looking for in order to trust the pathologist or to decide what is the next step. Again, the biopsy is safe, as I mentioned, simple procedure. It is not sensitive to detecting structural anomalies. It's an office-based. I'm repeating myself. Again, there is disposable devices. If the disposable device is not enough or it's bending, you can go for the reusable ones like the Novacurate and what have you. Again, when you do the biopsy is something and reading the results is something else. What to expect? You can have different reports from proliferative secretory benign or atrophic endometrium. You can have inactive endometrium, most likely if it's postmenopausal lady. Many times the pathologist will tell you it's insufficient, which is very frustrating. So this will take you on like an excuse to go ahead and do DNC hysteroscopy. But again, repeating it and doing it a couple of times in the one setting can overcome the issue of insufficient sample. Again, if there is hyperplasia, you have to know, is it simple or complex, and is there a tibia or not? Because if it's simple hyperplasia, the incidence of this the risk of this one to move to progress to cancer is only 1%. And if it's complex hyperplasia, the risk is 3%. If there is a tibia, it's a different ballgame. You basically, just for rounding the numbers, instead of remembering 1, 3, 8, or 29, just multiply it by 10. So if you have a simple hyperplasia with no tibia, it's only 1%. If there is a tibia multiplied by 10, it's 10%, which is around 8. Same thing with complex. Complex hyperplasia with no tibia is 3%. Multiplied by 10, it's 30, which is 29 here. This is very important to know because this will lead you to decide how you're going to treat your patient. Summary of recommendations for the treatment. Again, hysterectomy is the treatment of choice for women with endometrial hyperplasia with tibia who are not planning for future pregnancies. For postmenopausal women with atypical hyperplasia, it's advisable to do BSO. For perimenopausal women, it's controversial to remove the ovaries or not. Again, progestin therapy is an option of women with hyperplasia with tibia if you want to preserve fertility, given the fact that you'll be following the biopsy afterwards to make sure that the tibia has resolved. Approximately 35% of women will fail conservative management. So sometimes we have to end up by surgery. Progesterone therapy is a choice also for treating hyperplasia without a tibia. Sometimes you overdo things and complications can happen, and then you will be questioned, why did you do the surgery? I'm not saying that we shy away from doing hysterectomies, but again, we have to have a good justification before we do one. Progesterone, like we try midrogestrine acetate or amigase if we are having a tibia, and different ways of doing it. Now, we move to the progression of the hyperplasia with the tibia. Is the usual suspect, the old, or not old, the obese patient, which we see every week. I mean, our patients is not. I mean, there is morbidly obese and there is obese, and anybody who did the surgery of those patients know what I'm talking about. Again, endometrial cancer is the most common gynecological cancer. And the endometrial cancer is 95% of the all uterine cancers. I'm not talking about sarcomas today. We're just looking at the gland. Most common invasive gynecological malignancies, and it is if a woman has to have cancer, gynecological cancer, this is the cancer to have, especially if it's the endometrioid type, because it declares itself by early bleeding, and it is, if managed well, it's curable. Again, endometrial carcinoma is stereotyped with the disease of the obese patient, and the disease usually precedes hyperplasia. It gives us an alarming sign. It gives us a way of postmenopausal bleeding, spotting, bleeding, and then hyperplasia will progress with time. The problem here with our postmenopausal women is that they stopped having period for so many years, and then they're starting to spotting. They feel shy of reporting it. Sometimes feeling shy, sometimes till the bleeding is progressive, and because if it's interfering with their prayers and fasting and everything, they report it when sometimes it's too late. So part of our duties as a general gynecologist is to educate and aware our people that if you have spotting, please report it. Such tumors have an endometrial histology and usually of early stage and low grade. However, this is not the only type. There is a non-endometrioid histology which is more aggressive and more serious, like pap serous or clear cell carcinomas. Again, symptoms, 90% of patients with endometrial cancer can present with alarming signs like postmenopausal bleeding, but there is a good number that is asymptomatic. Again, we can pick them up by pap smear. A practical point, if you had a pap smear with endometrial cells in anybody above the age of 40, please do endometrial biopsy. Postmenopausal women, common is common. There is a bleeding with postmenopausal women, but the most common reason is atrophy. So we cannot just blame atrophy for every time. We have to have a good suspicion for hyperplasia or cancer, especially with the obese postmenopausal ladies. 60 to 80% of patients with postmenopausal bleeding have endometrial atrophy.
2 minutes.
Okay, about 10% of the patients have endometrial cancer. The older the patient is, the greater the risk of cancer. So we have to weight every patient differently. The natural history of this is the direct route of spread through the from the gland to the muscle to the serosa, and the endometrial cancer may spread to the pelvic nodes and to the pelvic nodes and the para-aortic chain. The occasional presence of malignant cells in the peritoneal washings can explain the migration through the tubes. Hematogenous spread can happen. Tumors with the clear cell and pap serous, as I mentioned before, is more aggressive. Staging is important, and it is a surgical staging. Why it is important? Because it dictates the prognosis and the treatment for these patients. Again, it's not only the staging, also the grading. If it's endometrioid type and it is grade 1 or 2, it is more of like a friendly cancer in compared to grade 3 or the other subtypes, which is papillary or clear cell. Again, staging changed recently, but again, it's becoming more like easier to remember. Stage 1 is A and B. A, if it's invading the myometrium, involving the endometrium and the first half of the myometrium. Stage B, if it's higher than the 50% of the myometrium. Stage 2, if it's reaching the cervix. Stage 3A, if it invades the serosa or adnexa. Stage 3B, if there is vaginal mets. Stage 4, again A and B, if it's rectal mucosa or if there is a distant metastasis. Again, this staging is important to decide or to tailor the treatment of your patients. Again, it depends on the patient age, location, and performance status. But the standard of treatment for the early stages is universal. Again, we are lucky because the stage 1 is the most common type, not like the ovarian cancer. It declares itself, almost 2/3 can declare itself by bleeding, and it's most of it in curable stages. Treatment, again, the cornerstone is surgical staging. The operation should be performed whenever possible. Yes, it is not emergency case, but it is as soon as possible. So if you have diagnosis of endometrial cancer from your clinic, please refer it to the gynecologist, who can be busy, but give them a call, tell them that I have this, if you can just book her as soon as possible. Some patients require sampling of the regional and pelvic para-aortic node. It's a different discussion by itself. Patients with stage 3 and 4 require individualization of treatment, as I mentioned before. Again, what is the prognostic factors? The stage, the grade, the receptor status, the patient age, and the vascular space invasion. The follow-up, we know that if the disease will occur, it will occur in the first 3 years, and it's going to occur at the vaginal vault, most likely. So we do look at the vaginal vault, we look at it, feel it, and sample it with pap smear every 3 months in the first 2 years, then every 6 months till we finish 5 years, then annually. Again, because it's cancer, it can recur, and the recurrence disease, approximately 3/4 of the patient who will recur, as I mentioned, locally. Isolated vaginal metastasis is an alarming to make us not only treat this, just screen the patient doing PET scan or what have you to look for disease somewhere else. Thank you very much.
Thank you.